Bayer Oncology. I welcome you all for today's evening program on prostate cancer update. So, and I welcome all the speakers and delegates who have taken their time out and joined for this evening session. So I'll hand over to Dr. Ramya A. Madam is a consultant medical oncologist at Apollo Cancer Center, Apollo Specialty Hospital, Chennai, to set the objective and take the meeting forward. Welcome, Doctor, and over to you.
Thank you so much, Mr. Shiva. Thanks for having us here. I thank the team of Bayer for bringing us together. Metastatic HSPC has evolved a lot in the last couple of years. There was a dearth of options sometime maybe a decade back or 7-8 years back, but now you see a lot of interest and research happening in this area, and by the means of which we are able to improve the outcomes in a long run, and we are seeing the clinical translation of this happening too. So with that in mind, it will be very interesting to listen to the two talks that we have today. The first will be reaching new heights in metastatic HSPC cancer care. And for that, we have with us Dr. Gayatri Gopan, consultant medical oncologist from GG Hospital, Trivandrum. Over to you, Dr. Gayatri. Dr. Gayatri. Dr. Gayatri, am I audible? Mr. Shiva?
Yeah, you are audible, ma'am. I think Doctor unmuted, but still we couldn't hear from Dr. Gayatri.
Yeah.
Gayatri madam, I think there is.
Can we go ahead with the second talk in the meantime? Can the team check with Dr. Gayatri?
Ma'am, give me a minute, ma'am. I'll talk to the doctor.
Please check and get back.
I'll check it, ma'am. Yes.
Am I audible now?
Yes, madam.
Yes, Dr. Gayatri.
Yeah, but the thing is that
Is Dr. Gayatri having some technical issues?
am I audible?
Yes, Dr. Gayatri, you're audible. You're muted now. Yes, Dr. Gayatri, please go ahead.
I'll start my presentation.
Gayatri madam.
Can you see these slides?
Yes, ma'am. Slides are visible, ma'am.
Can you hear me?
Yes, ma'am. Voice is here, but the slides are not in meeting.
The slides are zoomed in, Dr. Gayatri. You might have to zoom it out. And yeah, and put it in the presentation mode.
Yeah, Vinod, can we start with the next topic if Dr. Let Gayatri Madam join?
Is Dr. Dilip Harendran is here. Is it okay if we go ahead and start? You can help Dr. Gayatri to sort out the technical issue in the meantime.
Yes, I'm here. That's me.
Yes. So, Dr. Dilip, I'll hand over the meeting to you, and you'll be talking on advancing metastatic HSPP treatment horizons. We'll be concentrating on darolutamide without chemotherapy, the ARANOTE evidence. Over to you, Dr. Dilip.
Yeah. Are my slides visible?
Yes, doctor.
Yeah, I'm audible, right? Okay. So today my topic is on darolutamide, the ARANOTE evidence that's advancing metastatic HSPC treatment horizons in darolutamide without chemotherapy, which came after the ARASENS trial. So at the outset, I would like to thank Bayer and the organizers for giving me this opportunity. So these are my disclosures. So when you look at the standard of care in metastatic HSPC, it has evolved to combine ADT with AR inhibitors, abiraterone or docetaxel. So initially it was in 2014-15 where the CHARTED and the STAMPEDE arm C, which showed docetaxel plus ADT had a improved benefit in the metastatic HSPC setting. Then in 2017 and 18 came the LATITUDE trial and the STAMPEDE arm G, which showed the abiraterone with ADT as a doublet regimen which can be used in metastatic HPC. Then came the newer generation ARPIs, which are the enzalutamide, apalutamide in the ARCHES, ENZAMET and TITAN trial in 2019. And up to 2021, this was the standard of care. So now in our armamentarium, a new drug has come, which is called darolutamide, which was initially shown in the ARASENS trial with the triplet therapy of 2022. And again, 2024, the ARANOTE and ARASEC trial was the details were published of ARANOTE and ARASEC trial, in which the doublet of darolutamide and ADT formed a standard of care. So in between, there was a PEACE-1 trial which looked at the triplet therapy, abiraterone, ADT, and docetaxel as the standard of care. So despite all these treatments, a large proportion of patients actually progress to metastatic CRPC within 3 years. So what is the unmet need? So unmet medical need. So with the other ARPI inhibitors, there were major significant toxicity like CNS toxicity, and there was higher drug-drug interaction, which precluded the use of a complete dose of the ARPIs which are there. So the ARASENS actually was a phase 3 study which showed beneficial efficacy and safety profile in metastatic HSPC with the triplet therapy and led to approval in India in 2023. So next was the ARANOTE trial, which is my talk, which looked into the darolutamide in combination with ADT, whether it would provide efficacy benefit and favorable safety profile in metastatic HSPC setting. So again, the ARASENS was the background of the study, and ARANOTE was designed to see if doublet versus ADT provided a new treatment option in metastatic HSPC without docetaxel. So this was the study design. It was a randomized double-blind placebo-controlled phase 3 trial, which included 2 arms, darolutamide 600 mg BD plus ADT or placebo plus ADT, and they were randomized in 2:1. And the patient characteristics were metastatic HSPC and a histological or cytologically confirmed adenocarcinoma of prostate, with stratification factors were visceral metastasis and prior local therapy. The primary endpoint was radiographic PFS, and key secondary endpoints was OS, time to initiation of subsequent anti-neoplastic therapy, time to CRPC, time to PSA progression. And other pre-specified endpoints were PFS2, time to skeletal related events, and time to deterioration of FACT-P total. FACT-P total, the quality of life questionnaire. So again, 100% crossover was there in this trial, and data cutoff was June 7, 2024. So when you look at the patient characteristic, most important, almost all the characteristics were well matched between the arms. So when you look at the race, Asian population formed a major chunk, unlike many other trials. And there were a lot of de novo metastatic cases and high disease volume cases in the darolutamide arm. So as I told, there was a lot of representation from Asia, which included China and India and Taiwan. So when you look at the key primary endpoint, darolutamide plus ADT actually significantly reduced the risk of radiological progression. The RPFS at 24 months was 70.3% versus 52.1%. And the median was not reached in darolutamide, and median was 25 months in placebo plus ADT. This was the median follow-up was at 25.3 months and 25 months in the placebo group. And the hazard ratio for radiographic PFS was 0.54, and the p-value was very significant. So when you look at the subgroup analysis on the forest plot, almost all of the subgroups actually favored darolutamide arm, and specifically in the Asian population also it actually improved. Only in the visceral mets also it improved significantly. So almost all the age groups, actually almost all the subgroups, the benefit of darolutamide was shown. So disease volume, this was more important. The high volume disease again showed better benefit. So when you look at the key secondary endpoints, the forest plot, the overall survival was immature, but still it had a trend towards darolutamide arm. And time to metastatic CRPC was also, and time to PSA progression, time to initiation of subsequent systemic therapy, and time to PN progression. All of it was improved in the darolutamide arm. So this is another these are other two important subgroups which we have to look at in CSPC setting. It actually, the time to metastatic CRPC was significantly better in the darolutamide ADT arm versus placebo ADT arm. The hazard ratio was 0.4 with and the median was not reached in the darolutamide arm, and the median was 13.8 months in the placebo arm. And time to pain progression, again, darolutamide plus ADT, the median was not reached, and placebo plus ADT was 29.9 months with a hazard ratio of 0.72. So these are very important endpoints in a carcinoma prostate setting. So again, when you look at the PSA and PSA responses and progression, the PSA less than 0.2 was at any time, it was reached in around 62.6% of patients versus 18.5% in placebo arm. And the time to PSA progression was not reached in darolutamide arm versus it was 16.8 months in the placebo arm with a hazard ratio of 0.31. and a higher proportion of patients actually achieved undetectable PSA in both the high volume and low volume disease. When you look at these histograms, again, at any time it was 54.6% in daralutamide arm, 15.5 months in the placebo arm in the high volume group. In the low volume group, it was 82.6 versus 25.4. So again, time to subsequent life-prolonging anti-cancer therapy, it was improved in the daralutamide arm. It was only 32.5 versus 42.5 in the placebo arm. So when you look at, so daralutamide actually delayed the systemic anti-cancer therapy progression to another line. So when you look at the adverse events, this was also another key endpoint, because when you consider other ADTs like abiraterone and enzalutamide, the treatment related adverse events leading to permanent discontinuation was 6.1% daralutamide versus 9% in the placebo arm, and any adverse events was more in the daralutamide arm versus the placebo arm, and the grade 3 adverse events actually were also comparable in between both the subgroups, considering it was a 2:1 randomization. And the median treatment duration was 24.2 months in daralutamide arm versus 17.3 months in the placebo arm. And when you look at the most common adverse events, fatigue was the most common adverse event in the daralutamide arm, and others included some amount of AST, ALT elevation, hot flushes, and anemia. So the rates of adverse events associated with ARPIs were, it was actually similar across all the treatment arms. When you look at all the major adverse events like heart failure, hypertension, diabetes, all the metabolic disturbances, it was actually comparable in both arms. So again, this is another important aspect of daralutamide, the impact on hazard-related quality of life. When you look at the FACT-P questionnaire, the daralutamide extended median time to deterioration of FACT-P by 5.1 months versus placebo, especially because many metastatic prostate cancers live long. So the quality of life is actually very important. So the major parts which were controlled were the pain progression and the overall well-being. So daralutamide doublet therapy demonstrated clinically meaningful delays in the overall well-being, in the urinary symptom domain, the social and family well-being domain, and the prostate cancer domain. All the domains actually, daralutamide doublet therapy actually caused meaningful delays in the progression of each of these subgroups. So this actually is another this thing showing which all trials compared what. Charted actually compared high versus low volume. Latitude looked at the risk. Stampede again looked at the RT to prostate as has overall survival benefit. Stampede again, the other arm showed abiraterone can be used for both high volume and low volume disease. And in low volume disease, doublet is preferred. A high volume disease, triplet is better. And PEACE-1 trial was one of the trials before the ARASENS, which showed benefit in the triplet therapy with abiraterone. So conclusion, daralutamide plus ADT significantly improved radiographic PFS in patients with metastatic HSPC. Daralutamide showed a benefit across all secondary endpoints. Daralutamide was associated with a deeper PSA response regardless of the baseline PSA. Daralutamide is the only and first and only IR inhibitor to demonstrate clinically meaningful delays in pain progression, overall well-being, and has a favorable safety profile, and there are very less amount of drug-drug interactions. So daralutamide plus ADT without docetaxel should become an additional standard of care for metastatic HSPC, especially in low volume and low risk diseases. Thank you.
Thank you so much, Dilip. Dr. Dilip, that was a very comprehensive presentation. And I think this doublet, this combination of ADT plus daralutamide was always questioned. Why was it not there in the ARASENS? When ARASENS came out, why is this combination not there? And I think ARANOTE has addressed that quite well. And it being one of the least toxic compounds, I think it will be very welcome, especially in the elderly age group. for us to manage all the other side effects that happen with the other drugs. I hope so.
Yes.
So we'll move on to Dr. Gayatri. Yes, Dr. Gayatri, yes.
Yeah. I'll share my screen. Hope my slides are visible.
Yes, madam. Visible, ma'am.
Yeah. So, I would like to thank Bayers for giving this opportunity to discuss this very important topic, and I'm sorry for the technical delay. So, the topic for presentation is reaching new heights in metastatic hormone-sensitive prostate cancer. So, these slides were provided by Bayers. It's my disclosure. So, when we all know that prostate cancer, it often presents to us in a metastatic state. We get sometimes we get patients with locally advanced prostate cancer also. So when it is locally advanced prostate cancer, and then there is biochemical recurrence, and then there is progression to hormone sensitive prostate cancer, and then there's progression to CRPC, and it is the CRPC patients who eventually die. In some cases, we even diagnose patients in the metastatic setting even, which is, I think, which is more common. So here, our aim has to be here, that is a hormone-sensitive prostate cancer, and we have to delay the occurrence of castration-resistant prostate cancer, because it is castration-resistant prostate cancer that often leads to terminal illness and also death in the patients. And biochemical recurrence can even lead to non-metastatic CRPC also. So there, as Dr. Dilip has mentioned, there are so many trials in prostate cancer which has come way beyond 2013, and even now there are so many different trials are there. Stampede trial, Charter trial, Latitude trial, and so many different trials exploring the different molecules in this hormone-sensitive prostate cancer setting. And initially, we all know that androgen is main driver in the case of prostate cancer, and ADT is a very good therapy for prostate cancer. But it alone, we know that it alone does not work, though we use it in some cases. But ADT has some benefit in this survival, but we know that that alone is not enough. There is no sustained benefit, and we know that we can do much better in this case, and hence we have tried the addition of different molecules. In Stampede trial, we know that it is a multi-arm, multi-stage trial where we have tried the addition of docetaxel, we have tried the addition of abiraterone, even the RT. Many combinations have been tried in the case of the Stampede trial. So it has studied the effect of prostate RT for metastatic hormone-sensitive prostate cancer. We know that we have defined this high-risk disease in many ways, but one important way that is used in the clinical practice is a low-volume disease and high-volume disease, where low-volume or high-volume disease is defined as more than 4 bone metastases, one outside this pelvis, and other is the presence of visceral metastasis. When there is low volume hormone sensitive prostate cancer, there is definitely a role, the addition of prostate RT, but that can delay the progression to CRPC. And this was again studied in another Canadian UK-led PR3 study. And there has been so many different trials like JETUC trial, Chartered, Stampede, Latitude trial, the Arches trial, Titan trial, Enzamet, Peace, and now we have the Arasens trial. And this Peace and also Arasens, as Dr. Dilip has mentioned, that it explores the role of triplet therapy. So we usually we don't give ADT alone, and we try to combine some drug along with this. So we definitely can do better than ADT alone. So the Chartered trial explored the use of docetaxel in metastatic hormone-sensitive prostate cancer. In high-volume disease, there is definitely a benefit in overall survival by about 16.8 months. That is a very significant p-value. And there is a hazard ratio of 0.63%, almost a 40% reduction in the risk of death. But in the low volume setting, docetaxel plus ADT did not show much improvement in the overall survival. This latitude study again studied the role of abiraterone in high-risk metastatic hormone-sensitive prostate cancer. I guess most of us will be using abiraterone in the first-line setting, this metastatic hormone-sensitive. And this molecule, it is a hormonal agent, oral therapy, everyone prefers that. So even that has got a very good difference even in the overall survival. And the time to castration resistant status was 7.4 months. And there is a median time to subsequent treatment of 22 months. And there has been some debate regarding this latitude trial, but there is a very good overall survival benefit, and there are some side effects with this abiraterone, like this fatigue, hypertension, electrolyte abnormalities, and the use of steroids leading to hyperglycemia. But usually people tolerate abiraterone well. So these are the considerations for use of abiraterone in metastatic hormone-sensitive prostate cancer. Only 5 mg is used, but still there is a higher incidence of hypertension when we compare with placebo. Hepatotoxicity is high. The incidence of hypokalemia is high in the case of abiraterone. Cardiac dysfunctions, fluid retention, osteoporosis is all are the side effects that we expect in the case of abiraterone when used in hormone-sensitive prostate cancer. There is even an increase in this grade 3 and also grade 4 hypokalemia, and sometimes refractory hypokalemia can also occur in the case of the use of abiraterone. So again, there is a Titan trial. I have not used apalutamide till now, but apalutamide is a molecule that can be tried in the case of hormone-sensitive prostate cancer. And this has got an overall survival benefit and also PFS benefit with a very good hazard ratio. Whether it is high volume or low volume disease, there is a definite improvement. Enzalutamide is also a very good drug that can be tried, and the attraction is that we needn't use steroids in the case of enzalutamide. Again, there is a significant progression-free survival, overall survival, and even a PSA progression is also less in the case of this enzalutamide. And the tolerance is also actually people tolerate it pretty well. Even the 160 milligram people tolerate pretty well. So they demonstrate good efficacy in terms of overall survival and also significant benefits even in the low volume cohort. So that is the thing that we have to know regarding the EXAMET trial. So we know that ADT alone is not enough. Combining RP can be done only in the case of low volume disease, mainly limited to this pelvis. And we have tried the addition of the different molecules like this, all the available molecules, and we know that there is definite improvement. And hence the thought was like, why can't we combine further therapies like the triplet therapy? And there came the PEACE-1 study design. And the PEACE-1 was the first study to report on this triplet therapy. And actually this was, the study started way early. In November 2013, the study was started, and it was till 2018. It was designed to recognize the added value of abiraterone to standard of care, which at that time it was ADT. And then it moved through the study to ADT plus docetaxel, and thus we could compare the addition of docetaxel and abiraterone to ADT. So the inclusion criteria, the de novo metastatic hormone-sensitive prostate cancers were used without any prior therapies. So the disease extent definition was like high volume, low volume, and performance status, good performance status patients were included. And other inclusion criteria were less than or equal to 3 months of ADT prior to randomization and no prior biological therapy or cytotoxic therapy. And stratification is definitely on the basis of the performance status, the metastatic sites, the type of castration used. And so they have studied regarding the addition of the triplet therapy. So when we see that in high volume disease, we can see that the outcome is improved with the addition of abiraterone. In low volume disease, it doesn't seem to be as beneficial as the high volume disease, but we can try this in the case of very good performance status patients. We can try this, and actually the age group I think till 72 years they have included in the study. So again, there was a proper study, that is ARASENS study, that studied the effect of darolutamide and docetaxel along with LDT in the case of metastatic hormone-sensitive prostate cancer. So docetaxel 6 cycles, darolutamide 600 mg/d along with LDT was compared to placebo plus ADT as well as in docetaxel. And the patients with a good performance status who were candidates for ADT and docetaxel were loaded. And stratification was on the basis of the extent of the disease, the alkaline phosphatase levels, and this was how they had randomized. And the endpoints, the primary endpoint was overall survival, and the secondary endpoints were the time to CRPC, time to pain progression, symptomatic skeletal events, and worsening of physical symptoms and safety. So the study was designed prior to the results of Latitude trial, and so we can have a definite insight regarding this impact of triplet therapy versus docetaxel plus ADT. And as Dr. Dilip has rightly mentioned, darolutamide has got a better side effect profile because this does not cross the blood-brain barrier when compared to enzalutamide. So this has got less fatigue and also cognitive dysfunction. Sometimes we are afraid to use enzalutamide in the case of patients with seizures because enzalutamide can reduce the seizure threshold. But darolutamide does not cross the blood-brain barrier, and hence the incidence of side effect is less, but sometimes there can be some neutropenia or myelosuppression or transaminitis, but otherwise it is a well-tolerated drug. So it is easy to combine darolutamide with docetaxel. And again, in the case of abiraterone, another problem is that we have to give steroids also. Again, we have to manage all the complications of that event. So in the overall population, there is a clear improvement in this overall survival in this darolutamide. And in the high risk and also low risk patients, the hazard ratios were all very similar. So this is the patients who survive, the survival ratio. There is a good hazard ratio even. So the benefit was seen in all the subgroups, in the high risk group as well as a low risk group, which was different when compared to this PEACE trial. So the secondary endpoints also, the patients who did not progress to CRPC and also patients who did not have pain progression. Again, the secondary endpoints also, they have actually met the secondary efficacy endpoints also. We can see that there is a wide separation in graph, time to CRPC. So this is very significant because we know that CRPC, it is difficult to control and patients will progress easily. So this is a very important feature in the case of this ARASENS trial. So PSA response also has been very good, and more than 2/3 of the patients reached below 0.2 in the overall study. So overall survival, there was undetectable PSA at 36 weeks. So much higher PSA responses were evident in the triplet combination. And there is a significant increase in time to PSA progression in patients who achieved a PSA of less than 0.2. And there is a very good reduction in this death also. So that is, the hazard ratio is 0.37. That means there is a 63% reduction in the risk of death. So that is the one question that I had, like this, there is darolutamide and docetaxel and also this ADT. Can't we just give a doublet therapy and then give the other agent upon progression? But when we compare the two, actually using the triplet therapy is much better because it delays the onset of castration-resistant prostate cancer. So that is better when compared to the sequential therapy. So again, PSA response in the case of low volume disease also, there is a very good PSA response, and over 90% of these patients even did not have PSA progression. and there was a very good overall survival, as we can see in this graph. There is a very good overall survival with the hazard ratio is, we do not see such hazard ratios. So deciding between the doublet and also triplet in metastatic hormone sensitive prostate cancer, the patient has to be should be able to tolerate, and patient has to accept dosage cycles. But usually patient will tolerate it well, and the extent of disease has to be seen, and also what is the performance status of the patient, that also has to be mentioned. The age or the life expectancy, definitely that is a very important factor to consider. When the life expectancy is less, when the patient has multiple comorbidities, there is no point in giving all the agents. But definitely if the patient is young, there is a good life expectancy, very good performance status, limited comorbidities, then we can definitely consider the addition of triplet therapy because to delay the onset of CRPC. And patient needs to be informed of all the options. We should not be deciding. We have to inform all the options to the patient. So thank you so much for the opportunity.
Thank you, Dr. Gayatri. That was a very detailed presentation on ARASENS. And I think the introduction of darolutamide has changed the way we treat metastatic HSPC in different ways. Like the ARANOTE, we have particular group of populations we'll be looking at. The ARASENS, we have particular group of populations we'll be looking at. So I think it's becoming more, we have more options to choose from, and it's getting more individualized. So I'll present a case, and I think Dr. Gayatri and Dr. Dilip, if you are around, we can have a small discussion on how would you consider, how would this trial impact your practice decisions. So this is a real case that we had. 72-year-old gentleman, but very fit. He was sorry. I'm sorry. Am I audible?
Yeah.
So initially he had in 2017 BPH, and that was biopsy proven. So he's a very anxious gentleman. So he was on regular PSA follow-up, and after that, and in 2024 his PSA shot up to 92. He also had a lot of lower urinary tract symptoms, abdominal discomfort, back pain, significant back pain. So we were anticipating a lot of bone disease, and we were already preparing in our mind to think about a triplet therapy. But then when we did the PSMA scan and the MRI, the PSA scan picked up lesions in the prostate, but it was extensive lymphnodal disease across the abdomen, mediastinum, and the supraclavicular lymph node. So this is a very unusual presentation. When a person presents with such a significant back pain, automatically you would expect it to be related to probably a bone. And that is extensive, then it's not the usual present for any of us. So we did the prostate biopsy. It came out to be a Gleason grade group 5. And just for our satisfaction, we did an FNAC from the supraclavicular node also. Is it audible?
Yes.
So also metastatic carcinoma. Now let's look at the definitions. So Dr. Dilip and Dr. Gayatri, how do you look at the definitions for the high volume and the high risk? Are you satisfied with it? Would you go just by that, or is there something else that would make you decide on your treatment options?
Definitely, we have to see the high risk, and as mentioned in this charted trial, I usually use this definition. And on deciding the treatment, we have to see the performance status of the patient, comorbidities of the patient, where all he has got this mets, like liver mets, if it is there, then I feel that it is a high risk disease is there. So all these factors has to be considered prior to starting treatment.
Dr. Dilip?
Yeah, I also consider, I think this high risk, high volume is actually not, I do look at all these, I do look at these factors, but additionally, as Dr. Gayatri mentioned, performance status, and if there is any emergent need for, if the presentation is like with cord compression, all those things also I consider before starting a treatment. But the chartered and latitude criteria, I do look at when deciding, and especially the age factor. Age also, if it's a younger age group, again, I would maybe try to be more aggressive. So
Great.
these things.
Agreed. I think this is the best criteria that we have till date. And this has been, I think, proposed in 2013 or 14 when they started out the chartered and latitude. I think that's when they defined this criteria. The one problem that I have, or quite a few problems that I have with this criteria, is in the current era, it is very limited. Like, for example, our patient had extreme symptoms, PSA 92, a very well-informed, very fit 72-year-old gentleman, extensive lymph nodal chain across the abdomen, mediastinum, supraclavicular. He will never fit into any of the chartered or the latitude criteria. But the problem was, in practice, the current, I think it's evolving. I wouldn't say this is the best that we have. Whatever criteria we are doing now is the best that we have. But I'm expecting the criteria to evolve in the future to include much more than just bone mets and visceral mets. Like, we will have to consider the tumor biology. We'll have to look at the molecular markers. Now, we have a lot of molecular data coming into the first line also. So, for example, if the same patient is going to have a TP53 alteration, it changes the entire way you're going to approach the patient. It makes the patient a little more high risk. So, all of these nuances, I think we will be encountering in the near future. But we didn't have any of it in 2024. But he was a well-informed man. He literally sat with us with the survival curves of Arasins for low volume, high volume. He wanted us to put a definition on him. Where do I fit in? Because the definitions don't fit for him. So, but symptoms are very significant for us. The pain was significant, so definitely docetaxel goes without saying. And 72-year-old, no comorbidities, very fit but very anxious. So we decided to actually go with the triplet, degarelix, docetaxel, darolutamide. And we initially started with the doublet, the degarelix and daro. Once we slowly saw that he's tolerating, we added it after 2 weeks. Diabetes management was optimized, and surprisingly, the rate of fall of PSA was very fast. Within a month, it hit 2.9, and then you had 0.16, and then you had 0.08 in March 2025. And the scans that we saw were also very gratifying. The lymph nodes had responded very beautifully. Symptomatically improved I think by the second week itself, symptomatic.
Madam, we lost your voice. Okay, madam. Hello.
The Ramya is not audible.
Yeah, now audible.
I'm so sorry, I logged out. Where was I?
Yeah, here only. Yes.
Yeah. Which was the last one? You were able to see the PPT?
Ma'am, it was PET.
You were at the images, the PET scan.
Okay. No, is the slide visible or should I reshare it again?
No, it's visible, ma'am.
It's visible only. Okay, fine. So just a minute. So my question is, would you consider modifying your dose of docetaxel or to suit your patient's age or performance status?
Yes, we sometimes definitely we alter the dose of docetaxel because sometimes in elderly patients I give 50 mg per meter square 2 weekly. So I feel that patient does not tolerate, will not tolerate, or if it's an elderly patient, I think this is also a well recognized dose, giving 50 mg per meter square 2
Yes.
weekly. They tolerate.
That is very true. Dr. Dilip?
Yes. The 2 weekly doses actually I do use very regularly, especially above 70. And it's
Yes, I think docetaxel as such itself 3 weekly giving in that elderly population is a little tricky. Here he was fit, but because of a lot of other social factors and anxiety, we did go for a weekly dosing of docetaxel, and he responded quite well to that, both in tolerance and efficacy. And this is quite an old scan, about a year back. We did a recent imaging also. PSA is still under good control. We had to stop after about 5 full cycles. That is 3 weekly. Every 3 weeks we covered as 1 cycle, so we had to stop at 5 cycles because of more of a little bit of fatigue and intolerance started setting in at that point in time. So he's still continuing on Degarelix and darolutamide, and its current PSA is still very much under control. So this was the only reason I wanted to talk about this patient is he is technically not a definition for a high risk or a high volume as per the charted or the latitude. But we can't put him under a low volume disease also. And even in that situation, in an unusual disease presentation, this seems to have worked well, and he's still having a good quality of life. He celebrated his 74th birthday recently, and the quality of life is actually very good, just like what Dr. Dilip and Dr. Gayatri mentioned in their data points, that the quality of life is not affected, not much of side effects. So clinically, he is doing quite well. We have quite a few other patients also who are handling the triplet combination very well. But one question too, do you think Aronate will replace Aracins, Dr. Dilip and Dr. Gayatri?
So I'm not sure, but because in patients who have who are at this age group and doubtful performance status, I do give doublet therapy only, but I'm not sure if I'll give darolutamide for CSL. Mainly it's because of the cost only. So I do get good responses with apalutamide and enzalutamide also. But that being
Understood.
said, maybe in patients who have multiple comorbidities, who are on multiple medications, and for whom the side effects if we think that the side effects can worsen the quality of life, yes, such cases I would consider the Aranote trial.
Yes, Dr. Gayatri.
Yes, I agree with Dr. Dilip that giving a triplet therapy is not that easy. And also another more than is the problem is with the cost. There is some insurance and all, then it is possible because it is for a prolonged duration. Patient may not be able to afford all these things. So we will
Agreed.
my
Cost.
practice is giving a doublet. If cost is not a concern, it is a fit patient, definitely I would consider triplet therapy.
Okay. So, sir, how has your experience been with triplet therapy so far? You have faced any difficulties, challenges,
I have not given
apart
triplet
from the
therapy
cost?
with darolutamide. I have given
Okay.
darolutamide alone with ADT. That was for an insurance patient.
Okay.
And that I have got a good experience, like patient did not have much side effects, patient tolerated treatment very well. There was a very good response in
Okay.
PSA also. Patient is still on this darolutamide and also ADT. But regarding the triplet therapy, I have used only abiraterone, and because mainly that the cost is the main factor. But patient is a good performance status patient, and patient could tolerate it well.
Understood. Dr. Dilip?
Yes, so I have used triplet with darolutamide for one patient. He was a young 50, around 60 years age, metastatic HSPC. He presented with renal failure, obstructive uropathy. So I used a modified dose. Actually, darolutamide, the dose has to be modified based on the creat clearance. So when I checked in that, so I didn't use the complete dose. I started with the BD dose and then I increased to 102. I didn't escalate more than it, but he had a very good response and he's doing well. That is one case. Another case, actually, it was actually a trial after multiple lines. I tried this Aranote protocol, but actually that patient he had multiple brain mets and also at that time it was started. So
Okay.
that patient did not actually do very well.
Understood. I think all of these experiences matter for us to learn from each other. And I think, as you both mentioned, the population whom we choose for ARANOTE is going to be different. In like as you said, if a patient is okay for a doublet, there's not much of a high volume or a high risk, and then you have you don't want to give a lot of toxicity, then definitely the combination will come into one of the options. But on the other hand, you have a high volume, high risk disease and a very fit patient, then automatically the triplet is going to say. So ARASENS, ARANOTE, each are going to have their own set of patients who will be fit for the protocols to be used. So I think thanks Dr. Dilip and Dr. Gayatri have beautifully summarized the two trial protocols. And I think these are exciting times in HSPC for us to see more and more novel data is coming, novel options are coming in, different triplet options are coming in. So I think it's time for us to wait and see. But if Dr. Dilip and Dr. Gayatri, if you both have any questions or any discussions that in mind, let's leave the floor open.
Oh, I don't have. Only thing is, if do you check BRC upfront in all?
We do. We have started doing it. We started doing
Do you combine
NGS.
olaparib with one of
The
these?
rate of if you finding a BRCA mutated prostate cancer is quite low, at least so far what we have tested. We have recently started testing, so I think the more we test, we'll pick it up more. HRR genes we do pick up, but we have not yet done it in the first line setting.
And the rates are very low. MSI
Very
and
low.
also we are seeing.
Yeah,
Possibly-
MSI is having any DNA repair alterations are less than 10%, and MSI is hardly low. BRCA alterations even low. So the more we test, the more we are going to pick it up. It is moving up into the first line, but I think we'll have to look at Indian data to decide how good it is. We still have a long way to go there.
SI, even if it's positive, I would take it with a pinch of salt in prostate.
Yeah.
So
Not
it's
right now.
an immune cold
We-
environment. So
Yeah,
I'm not sure
it's not right. It's not. You're talking about immunotherapy, is it?
cases, if I wouldn't start on immunotherapy first itself.
If the patient is MSI high.
Yeah.
Yeah,
Because
I agree.
I think it's an immune cold disease, the prostate. It's not a very immune.
Understandable. So, if no,
And
yes,
then-
Dr. Gayatri, what about to say something?
Yeah, another one thing is regarding the experience of darolutamide upon progression post multiple lines.
That was the first setting actually we initially tried. When Daro came into the picture, we had a very heavily pre-treated patient who had very good performance status still, but we had already run out of quite a lot of options. So we did the triplet in him. We did the docetaxel. We reintroduced docetaxel and did darolutamide. We could get a PFS of close to a year. So it did have an effect in that setting also. That was one of the earliest patients we tried, and then we moved on to the conventional HSPC setting, and our experience has been good so far. As I mentioned, cost is a factor, major factor that determines the accessibility, but I think Bayer will find a way around it. I think if no more questions, can we end the session, Shivkumar? Anything from Dr. Dilip and Dr. Gayatri?
Oh, nothing.
Dr. Shivkumar, back to you.
Thank you, doctors. Thank you very much for a very interactive and a very informative session. All the three speakers and excellent discussion. Hope the audience will be greatly benefited. Once again, I take this opportunity to thank all the three speakers as well as the audience for attending the session. So we can conclude, and over to you, Testing. We can conclude the meeting.